Hello and welcome to our webcast. I'm Amy Pendergrass with Moss Adams, and I'm going to get us started for today's session, How to Audit and Monitor Telehealth. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
All right, and now I would like to introduce today's presenters from Moss Adams. We have Laubach, partner, and Sabrina, Butler, manager. Their bios and contact information are located in your webcast console if you would like more information. And now I would like to turn the floor over to Lori to get the presentation started. Lori?
Yeah, thank you, Amy. I appreciate the information about us, and I just wanted to give a little highlight of both Sabrina and I. I am, as she mentioned, a partner, but I'm in charge of the regulatory compliance and healthcare internal audit for the firm. And Sabrina is a manager, and she's extraordinarily knowledgeable in telehealth and has been a manager with us focusing on regulatory compliance and revenue integrity. So today, I just want to say thank you for joining us today to discuss our telehealth and how to identify areas of potential risk and some thoughts on how to potentially audit it as well. As we heard not recently in a conference, telehealth has really been raised to high level with the regulatory agencies. And since the volume has increased substantially due to the public health emergency, the government has raised concerns about documentation, medical necessity, coding, and billing. Telehealth regulations have been ever-changing, and it's been hard for us to keep up with those. But we've seen a lot of different issues that kind of go down to the base requirements of telehealth. And it's not just the documentation, but it's also what's getting put on the claim. So we thought we'd start today with just a status of where telehealth is, what's on the horizon, what we're seeing for telehealth risk areas, and just some thoughts about auditing and monitoring from the perspective of what we should think about as we put together an audit. So we have our first polling question. Amy, will you bring? So has your organization implemented a telehealth program? So when we've asked this question to a variety of folks, we've gotten different answers as we worked with them on preparing for an audit. And it'd be great if you can give us some input about if your organization has implemented a telehealth program. And Amy, do you want to remind everybody about the requirements for CPE?
Sure. So we will give you a few moments to respond, and I do want to let you know that to respond, you will need to click the button next to the answer you choose, and then make sure you hit the Submit button. And then if you cannot see the submit button, you will need to enlarge the slide area because the polling questions are right on the slides. And then also, you will need to respond to at least 3 of the 4 polling questions.
Looks like we have quite a percentage of everybody that's responding. Little time to get caught up with the time of the morning and having your first cup of coffee.
All right, I'm going to pull up the results here.
So it looks like about 65% of the folks on the phone call have actually implemented a telehealth program, and there's about 20% that's not too sure. So it'd be good to start asking those questions as you start to dig into the risk areas that we're going to bring forward. Our next polling question is, what are the primary areas for deployment of telehealth for the future? Is it because of chronic care, primary care, behavioral health, physical therapy, cardiology, other, or not sure? We've actually, Sabrina and I just spoke about, what people are using telehealth for, and just that whole mobile technology approach to using telehealth, telemedicine, all that type of thing. Everybody respond? We're still at about 30 of 231. So it was interesting as we talked to people in the audience, not only telehealth is something people are doing, but also some of the mobile clinics and other ways to providing care to their members of a health plan or treatment for tribal members, because we were speaking of a tribal event. So just different ways to look at how you might want to go ahead and deploy it for the future. Okay. Shall we move on, Amy? So it looks like majority of everybody is going to be the primary care behavioral health. There's quite a few that not sure, so just kind of thinking about how you're going to be using the actual telehealth services in the future. And there is somebody who has there's some feedback. If you haven't muted your phone, please be sure to do that. And I'll now pass it off to Sabrina to start talking about telehealth today.
Thanks, Lori. It was really interesting looking at those polling questions because we had a lot of primary care and then we had some ancillary areas. And one of the things we wanted to really communicate to the group on the phone nationally today is, CMS has commissioned a study about telehealth, and that study was talking about flexibilities in how and what the pandemic allowed for deployment of telehealth across the nation. And so they're looking at areas like virtual care supervision, remote patient monitoring, and we're going to talk a bit more extensively about those today. But keeping that in mind, and thinking about it from a billing and coding element, we're also thinking about telehealth from an arrangement perspective, subcontractors, referrals, those types of areas where we have operational and scope of licensing issues. So we'll get a little bit more into that as we move through the program today. Hopefully this is advancing for me. There we go. So what's going on? So let's talk about this a little bit. And we have quite a bit on the slide. But I want to talk about areas of national interest. We have such a dynamic group on the phone today. And one of the things that has come up very frequently and very recently, especially for me as people are asking me about telehealth, have been state rule expenditures and the waivers expiring. So we know that through the pandemic, we have had states issue waivers allowing us to perform and engage in telemedicine services in a pretty broad scope. We've been able to cross state lines. We've been able to do all kinds of portability and delivery models. As that has changed and as we have moved through the pandemic, we've had states pulling back waivers. And one of those things that I was talking really recently about was the state of California and the state of Nevada. And I bring that up it just is an interest. So in the state of California, for example, where I'm actually located, our state rules are very specific and state that you must have a license in the state of California to provide services to any patient via telemedicine in that state. When we look at other areas, for example, state of Ohio or the state of Pennsylvania, there are a little bit more flexibilities in the sense that the state of Ohio allows for established patient relationships to occur, and you can cross state lines. If you're a provider in Pennsylvania and you need to see a patient in Ohio, you can do that if you have an established patient relationship, and you don't have to go to Ohio for state rules. So one of the things that Lori and I have really recommended is everyone take a step back and look at what's happening in your state and in your state compacts and agreements with states around you for how flexibilities and waivers are moving forward. These are going to impact us pretty significantly. We've seen increased rates of management of chronic care, patient remote monitoring, and I'll get into those a little bit more as we move through our presentation today. But I do want to comment just really briefly about parity and payment. And we are going to see some changes in this area as we move through the pandemic, as we look to the pandemic potentially ending. I haven't seen any news this morning yet about whether Secretary Becerra has moved that forward. But one of the things about parity that we want to think about is Medicare has, and CMS opined pretty recently about payment parity. And we've been receiving payment as if we saw the patient in person. So we've been getting paid a rate that we would normally get paid. 25 states have really talked and engaged in Medicaid payment parity and reimbursement for the providers performing at in-person care, and 25 states are working to ratify payment parity. The others, not so much. They're not as interested in it. CMS has indicated pretty recently that they're considering a facility payment model. So you would not be receiving the same amount of payment as if you saw a patient in person, but there could be potential RVU impacts. So things to be thinking about. And I'll talk a little bit more about supervision rules, eligible providers, and frequency limits as we move through the presentation. So OIG audit activity, and we have the majority of us in healthcare have really paid attention to that July 22nd fraud alert. And that fraud alert, comes forth and it gave us some characteristics that we should be looking at for fraud schemes in our relationships as healthcare entities. And some of those things are purported to be medical providers reviewing records electronically, signing orders, prescription medications, and not actually treating the patient, and some of these internal arrangements. We do recommend that everyone take a step back and really look at what the OIG has indicated from a audit perspective in the work plan, and look at at your organization for what is actually occurring for you in your payment and vendor relationships. So the slide advanced for me. So, but let's just talk briefly in chat about the documentation, coding, and billing components surrounding telemedicine. So we'll talk about the proposed changes. So comments for the proposed rule for the physician fee schedule were required by September 6th. And at the time of this presentation, a finalization was pending. What we do know is that Medicare has indicated that services and proposed policy changes are going to be maintained through the public health emergency up to 151 days following the conclusion of the PHE. And after that period, CMS is proposing removing many of the services that had been temporarily allowed, including audio-only services. So CMS proposed maintaining many of their services, but we have not seen finalization of that action. And while they're legislating and making recommendations to us, we are seeing discontinuation of things like virtual supervision. And, we have seen virtual supervision used in various ways during the public health emergency. For example, rehabilitation medicine in outpatient facilities with a virtual provider in a separate state. CMS was really concerned about the quality impacts to patients where these services were occurring and we had this virtual or indirect kind of direct supervision. So they are backing that, they're walking that back and essentially saying, hey, we are going to discontinue this mode. We are concerned about patient safety. They've extended, as I indicated, some temporary codes. They've added some 54 codes to that temporary list, but we are not seeing legislation right now that indicates moving forward that we're going to have all of the key elements that we need to continue acting under the public health emergency in the future the way we are right now. So moving on, again, they have changed some areas that are of interest, and I have indicated on the screen some proposed physician fee schedule changes to remote patient monitoring. You'll notice that I have indicated the type of provider here. It's worthwhile to have your billing and coding or revenue integrity teams taking a look at these codes and how they're utilized in your organization. We do have some rules now around who can perform what service type, so reserved for physicians and NPPs, and reserved for non-qualified physicians. So taking a look at these service lines and how they're utilized in your organization is going to be key to moving forward with these proposed and updated changes. I do want to stop here and really talk a little bit about mental health. I've introduced some language throughout the presentation called telemental services, and we actually heard that directly from CMS. But I do want to kind of pause and stop here on the place of service updates. In April and then again in May of 22, CMS provided us 2 place of service updates. Place of service 2 being telehealth provided other than in a patient's home, and place of service 10, a new one, which is telehealth provided at a patient's home. At the time of this presentation, CMS has indicated that they do not see that these service lines should go, these new changes should go into effect right now. And what I mean by that is that CMS is saying that, yes, we want you to get ready for these changes, but that we are not going to be placing these into effect right this second. Now, that being said, Washington State's AppleCare, which is their Medicaid program, has initiated these place of service code updates. And that's really relevant to a lot of the people on the call. So Medicaid has started this process. So it's really worthwhile in taking a moment and actually looking to see if your Medicaid or state agency is actually beginning the utilization of these codes and making sure that they're part of your coding patterns, your revenue integrity teams, those types of things. From a mental health perspective, Medicare has made permanent mental health benefit, yay, which is wonderful for our behavioral health agencies who've utilized this rather extensively to provide behavioral health across the country. So patients can receive care in their homes. They can receive it for the purpose of diagnosis, evaluation, or treatment. There are substance abuse programs that are permanently enabled through the Medicare telehealth benefit and program. Commercial carriers and Medicaid and state agencies are funding this via billions of dollars. CalAIM in the state of California, $1.4 billion in mental health benefit to the patients. This is a tremendous achievement, and it's a tremendous achievement for providers. One of the things I want to make sure that people understand is that while the permanency has come forward with telemental services, and that's the big buzzword right now, telemental, these are not permanent. These services are not permanent for our family practice doctors, right? So we need to make sure that people understand that behavioral health and its modalities can move forward with behavioral health services. These are permanent under CMS, and I think that was a question. Would this rule apply to straight Medicare? Absolutely, 100%. So patients have this ability, and I've provided further guidance in the reference section for you to give you a lot more information on the mental health benefit. So we're going to move on here and move to our next polling question. So remember, make sure you select and hit submit for the polling questions. The question is, what is your primary area of concern with your organization's telehealth program? Is it compliance with regulations, privacy and security, the public health emergency ending and how we're going to change and move forward with that? Your patient's dependence on telehealth? I don't have any worries. No problem. We've got this. I'm not sure. So right now I have 82 of my 241, so 34% of attendees. So one of the things, I speak about a lot is behavioral medicine with telehealth. And I think it's really key that everybody really understand that the application of telemedicine, as you guys are filling this out, we have 73%. So just a few more here, is that, behavioral health services are available for us and for our patients, but we want to take a look at how future impacts are going to apply to family medicine, those areas. Okay, great. So Amy, can you help me? Great. So 41%. Our concern is about compliance with regulations, and that is a great segue because Lori's going to really talk about the risk areas. So Lori, I'm going to pass this slide off to you under the risk areas.
Thank you, Sabrina. That was great to go over what's going on with telehealth today. And as you can tell, there's probably a lot of risk areas that just came to light, and apologize for her OIG slide moving, but I think we have an auto move going on, so apologize for that. So let's just talk about some risk areas. As Sabrina was talking, you're probably scurrying and writing down a bunch of notes about things you might want to think about within your own organization. But I wanted to kind of go over some coding, some revenue cycle, and other items that we've seen as we worked with our clients through their audit or their implementation and things like that. One of the first things we see is that workflow was put together really, really quickly and may not really be efficient and may not also be compliant with the regulatory requirements. That means, are we getting the information necessary into our notes or into the record related to consent and other things like that? And then whether or not the use of telehealth supports the medical necessity and service meets that quality standards, let alone service expectation. We know that that the Office of Inspector General is is brought up several times about quality and service is meeting the service expectations of the patients. So we want to make sure that when we do our reviews that we're looking at this from not only a coding and documentation perspective, but also whether or not there are any concerns about whether or not this is the right method to be able to provide the care to the patient. Sabrina is going to talk a little bit about supervision in a couple of minutes here, but I think that she had touched on the practitioner-patient relationship as she was talking about, working across state lines and things like that. But it's really, it's according to the Department of Justice, there's a lack of meaningful interaction between provider and patient. I'm going to read exactly what it says, and the ordering of medically unnecessary products or services. So this happened during a lot of those takedown cases that happened last year. So there was a lot of cases where they alleged inappropriate patient marketing, potential patient received a cold call followed by a telephone examination, and then the patient expressed a willingness to speak to a provider. it really needs to be a sufficient patient-provider relationship, and each state has a bit of a different piece to this. So you'll want to make sure that you're aware of all the states that you're in, and then make sure that you understand how it's being used within your organization, and just the type of technology is also a piece of this as well. Is in some states they say the state allows anything less than a synchronous audio video interaction. They don't always allow that. So make sure you understand that. The other item on here is the outcomes, and that's really making sure we're tracking the outcomes of the care that we're providing within our telehealth services. And that's tracking things like efficiency and satisfaction outcomes, patient-client complication and morbidity, and what's happening with those patients that had telehealth services. If there's diagnostic accuracy, are they, diagnosing it properly, or are they, is that actually documented in the notes properly? Adherence to clinical protocols, and then just really having some type of cost per case that you're calculating. But I think one of the things that I've seen a lot of is really efficient is to track the delays in assessing those consultations to referrals or specialty practitioners getting referred to them. So that's just some of the biggest gaps. And so can you track that? Do you know what it is? Are there some gaps that maybe you need to dig into? Sabrina, do you just want to touch on the risk related to supervision?
Yeah. I think, I did mention it, and it's really about quality, but it's really about the fact that are we actually providing do we actually have a licensed provider in the state that we're actually providing that service to the patient, regardless of the establishment of the relationship with the patient? And I think that we have really seen an impact from the government, from the OIG, from the Department of Justice, talking about, as Lori indicated, kind of that interaction between the two. And do we have the right type of supervision occurring in our facilities where we have this telemedicine oversight? And they have really said, we are very concerned about this area, and we are going to take this back. And the general supervision rules are being walked back more and more and more, much like we saw with the take back of ambulatory surgery centers and that level of oversight. And can I have these inpatient only services performed there? They said, hey, there's a quality issue. So I really think, like Lori said, it's really looking at what gaps you have, what services you're providing. And we've seen that some systems, because they were operating under the pandemic and moving as quickly and efficiently as possible, they have not obtained and initiated the oversight levels that they really need to take a look at what they're actually doing. So it's really just taking a walk back. Thanks, Lori.
Yeah, great, because it's a lot of information in there, and how you can actually follow through the documentation to see who was actually providing that supervision too. So another couple areas to think about as you get into telehealth is there was a lot of training that happened at the heat of the moment. And then there was some more training as more guidelines came out. Then there was more training after that. And it was just trying to keep up with the guidelines and know what was going away with the waivers, what stayed with the waivers, what the waivers are still there. But when we go in, one of the things that we ask for is the training that's happened and who's attended that, mainly to find out, is it something that is available to any provider if they are questioning how they should document or get the consent. So just really understanding how that training occurred and where can you get your hands on it. One of the things that we do as an IRO, independent review organization, is that we often have to go back and trace, did that provider had the training that needed to do the work that they needed to do. So that might be an audit element you add to see if there was some type of impact due to that. We want to make sure that there's monitoring processes around telehealth. It doesn't mean that you necessarily have to do 100% unless your system doesn't have the right edits or monitoring features in it. I've seen some organizations do 100% because they don't have the right controls, or the system isn't have enough controls for you to do the actual work queues and things like that. And so we want to find out what is it that they're doing to stop a telehealth claim that might be a risk item to your organization. If it's 100%, you know it's 100%, then you need to probably audit what happened by that edit and who applied that change to that coding, if it went back to the provider or not. And so what is that hard stop to ensure the support is present for the service? And then, one of the things we notice is that when we've gone in and done audits, we've seen where telephone encounters were billed, but it turns out it was a medication renewal, and it was taken by the nurse, but the doctor bills for it. And Sabrina can correct me if I'm wrong, but they really shouldn't be doing that type of billing for that service. And she's shaking her head yes, and that's to make sure that, are we looking at it? And we found there was a significant amount in the volume of those that occurred. So it's just making sure you understand how, what's going through. And then do we really keep track of those changes? And sometimes we'll ask them, when you saw those changes that occurred during the PHE, and now as we, roll into the end of this year, are we tracking those changes in the regulations? And what were the workflow changes, and when did they happen? Because we'll find out as we dig into it that workflow didn't actually happen on the date that it, we started billing for, the waiver came in, or they added a certain CPT code, things like that. And so really understanding when those updates occurred and the systems were moving, as fast as they could, as well as your poor IT staff and revenue cycle. And then this whole thing around privacy and security. The Office of Civil Rights has been very clear about, making sure that there was, privacy and security as best as you possibly could. There was a waiver that's we're going to talk about in a minute. But from an operational perspective, do you have a process to ensure that there's controls related to privacy? In particular, is there a process for patient validation, authentication, as there can be patient identification? I can't talk today. Since no registration desk, there's more reliance on the provider. Or do you have something ahead of time that allows for that to be checked? And then do the rush of getting that telehealth going. There have been some misconfigurations of the telehealth during that, or they put together a platform that may not be meet the standards of the OCR for privacy and security, or they're still using texting on their personal phones and things like that. What are you doing to implement a platform that can actually help you track some of the information? And then the last one is that patient data loss. That's where you have a lack of technology available for when you have some type of a downtime with your system or a downtime with the patient, a variety of things, or that data can be lost. It's also thinking about that confidential space at the home of the patient. I've heard providers absolutely love it because they actually can see where that person lives and all the challenges, because they keep saying, why do you keep falling? Well, you can see that they have many things that are blocking them across their floor, to actually making sure that the patient has the technical capabilities in their home. As we know, many people can't afford certain data plans, and they also don't have access from a broadband perspective. So as I was alluding to, the Office of Civil Rights in June indicated that that they had issued some guidance on how providers and health plans can use that remote technology. And the guidance helps you kind of continue to look at how to help individuals with audio-only telehealth, but they want to make sure you stay in compliance with those HIPAA rules. So keep an eye on that, look at that guidance. So from an oversight perspective, some of the challenges we've seen as we start to dig into doing audits of our clients is particularly around scope of license. During the PHE, there was ability to use some of these ancillary providers, the respiratory therapists, people that don't necessarily are on the qualified provider list for Medicare. And so that is a situation where as the PHE ends and the period of time afterwards, you're going to need to start looking at who has the right scope of licensing to be able to perform these services. Without the proper supervision that will be in place to ensure that they're appropriate. So an example would be is hospital providers who cannot bill, they're not supposed to bill like a respiratory therapist. The hospital may bill for the outpatient hospital services provided by the staff using this telecommunication technology. They should look at review the requirements for providing hospital services in those relocated provider-based departments where we use the patient home and temporary expansion locations as appropriate. So you just need to make sure that as the risk is that Medicare cannot pay for services that are furnished by a physician or practitioner located out of the United States. There's a piece there too. And then there's much about the, regulations discuss the concerns of providers or non-providers use telehealth services, but the service is not within the scope of licensing. That's really where we need to, and making sure the right CPT is used for the right provider. So really, not only is it the right person doing the work, but it's also, is it the right CPT to align with that particular type of provider. And then some of the things about the identity of the patient preferred physician of services, I mentioned it on the part about privacy, but CMS has put together, HHS has a website on telehealth that has several guides in there, and one of them is how you're supposed to be checking the identity of the patient. Although they might look at it from a Pollyanna point of view, saying things like, if the patient is new, introduce yourself, confirm the patient's identity, and have them show your driver's license or valid photo ID. So I think, is there something else that you could do to allow and provide that provider some assistance to get that information beforehand? I'm going to talk about a couple other things and then pass it back to Sabrina on the consent piece. But hospitals have the originate site or furnished remotely ability. So that means that they're able to bill during the PHE, the HCPCS code Q3014. That's the originating site facility fee, which I was just talking about. This is when a hospital provides services via telehealth to a registered outpatient of the hospital. During PHE, they can be located in a provider-based department, including the hospital or patient's home. If the distance site practitioner furnishes the telehealth services to a registered hospital outpatient, and hospital staff and there is hospital staff that provides administrative and clinical support, then the hospital may bill the originating site facility fee. So there's actually a really good graphic in the FAQs that came out with telehealth, but note that this needs to be provided, the telehealth service needs to be provided furnished by a physician or other practitioner located at the distance site in order for the hospital to bill for it, and these are for just professional services. That's something to keep in mind if you're a hospital. And then providers or employees moonlighting. This one is something to think about as you had to reach out and find providers to help you with this care during the PHE. And that is really making sure that you understand the providers and if they're moonlighting with other services, other companies during the off hours. These same providers may not ensure that they engage with reputable telehealth companies. They're excited about the telehealth company. They don't know that they're actually something of concern, and they may get caught up in some type of alleged telehealth fraud arrangement and be a focus of some type of takedown. And that's happened to a lot of providers during a couple of those takedowns as they were doing the moonlighting. It also, that will impact you as an organization and how you need to look at that particular provider. But it's just ensuring that you understand where they're moonlighting and that they understand the risk related to that. And so, Sabrina, do you want to talk a little bit about informed consent, please?
Sure. Thanks, Lori. So informed consent, I can actually probably teach an hour course on informed consent. But one of the things we've seen is blanket consent forms that are being utilized where we're actually not seeing documentation clinically in the encounter of the consent of the patient. And one of the things that we actually will cite actually a couple times throughout the presentation is that while Medicare does not require an informed consent be obtained from a patient prior to the telehealth delivered service, a majority of states do. And it's really a key understanding, and it's part of your conversation with your leadership in your organization and potentially your legal team to make sure that you understand what your state provisions are for the consent of a patient. And we've seen informed consents, for example, in the state of Texas, where it was some blanket consent. It did not contain the appropriate information for telemedicine, and the state of Texas said, hey, you have to do this differently. This is not right. So it's really taking a step back. And I won't belabor it too long, but I did kind of want to talk through that just really briefly. Thanks, Lori.
So now I'm moving on to revenue cycle.
Yeah, so I think, here we're seeing a lot of misunderstandings. Should I use the GT modifier? Should I use the 95 modifier? What should I do for the place of service? Should it be 11? Should it be place of service 10? And I think that as we've evolved through the pandemic, we've seen some of this, done more appropriately. At the beginning, we saw a rush to just comply and to provide the service and deliver. But a lot of organizations haven't taken the time to go back and look and say, do an autopsy of how did we implement, how did we get this accomplished the right way, how did we audit this, or did we audit this? And I think that these areas, non-covered services, place of service inaccurate modifiers, are we surprisingly still seeing these issues going forward? Are our providers actually listing the right modifier in the right place of service on the claim? So we have seen place of service 2 used instead of 11, 11 used instead of 2, and it goes on. From a provision of unallowable services, can a chiropractor provide telemedicine services? And I asked this question to the group as a whole. Can this happen? Well, not really. And in some cases, yes. So there, it's really understanding who can provide services and are the right people providing services, and are we billing in the right way? And a lot of organizations haven't had the opportunity to just take a step back and look back and say, gosh, do I have the right people in the right places? Licensed professional counselors, licensed addiction counselors in behavioral medicine do and can, through expansion processes, have the licensure to provide these services via telemedicine without specific levels of supervision. And so do we have these right things in place? And I think, Lori, one of the things I always ask you on this slide is, to provide any comment you have regarding credentialing. I think that you always have good insight
here.
I
think, the concern, as I mentioned on the previous slide, is just this whole thing with moonlighting providers. But we also had to hire on some providers or contract with providers and get them credentialed really quick. And there was a lot of leeway during that period of time. Should we go back and look at that and determine if those providers that provided that service actually are no longer providing services for us, or they are we've seen where electronic health records still has them as valid providers, but they're no longer doing anything. And so we want to make sure that it's also closed down from a user perspective. And so just kind of thinking through that.
Documentation. Is it sufficient? Is it medically necessary? Those are the key tenets of what we do clinically from a documentation standpoint. One of the things that I can comment on, and just taking this slide for what it is, are you documenting start and stop times? And I can tell you that systemically has been a template challenge for providers, understanding for clinicians across the country, that I have to change my thinking, and I really need to start documenting start and stop times for how long I'm performing the service via telemedicine. And it's one of the things I see most frequently. It's one of the things people ask me most frequently. The teaching physician supervision rules are very interesting with consent. And in many cases, states, CMS have allowed teaching physician rules through telemedicine. If you have further questions about teaching physician and supervision, please just email me or write your name in the chat, and I will send you that information, because those rules have changed a bit throughout the pandemic process. We do have some flexibilities there. But if I'm giving a national speech, and I am right now, but one of the things I would say is, are you checking the start and stop times in your documentation to help you support your telemedicine service? And I think that to me is one of the key indicators. And is that consent there that I'm performing this service via telemedicine and that the patient understands in my clinical note. So key things, but if you would like further information on any of these areas, just feel free to reach out.
Yeah, I think there's two other items I was going to bring up, and there was a question about start and stop times. But first thing I was going to bring up is I know in behavioral health, the challenge to get the treatment plan signed during the PHE and getting those into your record with the right dates. That's a big one that we've seen everywhere. And then the second one is virtual check-in and e-visits. They're a certain amount of time, and they also have a series of codes. So you can easily data mine that and see if those are being properly documented for that care. And did you want to answer the question about start and stop times, Sabrina?
I'm having a difficulty seeing that chat.
Oh, it says, are you saying that start and stop times are required?
I'm saying that it's highly recommended, that we are seeing specific state provisions, that we are seeing some national provisions that do recommend the start and stop time. Am I saying that it's required? I can go back and pull the regulations, but that we highly recommend that start and stop times are entered. So I would look to your state regulations as well, but we've seen systemically that the lack of start and stop times has caused pause with Department of Health and Human Services auditors and some commercial auditors along the way. So I think it's actually very worthwhile to have the start and stop time in there. And it's not a huge challenge from a template perspective, but I'm happy to provide further information offline.
Thank you, Sabrina. And I think we're going to move into our next question, and has your organization completed an audit of the telehealth programs? So just kind of continuing to ask, the question of, what type of audits have happened, what have been the struggles you've had with your audits, and then, maybe you need to start thinking about these risk areas. And we're going to talk after this about some of the things you might want to think about as you do the audit. And I know there's a few things that are that have been showing up in our questions, and we may have to answer those, that information later, and we'll follow up with you directly. And there's been a few questions, and I know that Amy's been responding to folks, but this training is being recorded so you can listen again and see all the slides. So just from that perspective, we're happy to do. I think every time we've done this presentation, it's been a little bit different. So we enjoy talking about this area, which is a little geeky. So let's just kind of look at what we have so far, so we can get some more time to finish up our slides. Unless we need to get to 70–80%, don't we? Yeah, it was interesting during the conference we attended. CMS and OIG presented, and they kept bringing up, medical necessity. They kept bringing up quality of care, and it kind of reminds me back in, this tale dates me, but back in 1999 when all those SNFs, or all the hospitals and teaching facilities were audited, and that's where the PATH audits came out, and all the challenges that came from that period in the nursing homes from the quality of care. So it's just very interesting. Okay, so we have 28% or so that have had an audit of their telehealth program. There's about 31 that has not, but there's 41 that still needs to figure out and determine how that audit came out. So we're going to jump into auditing and monitoring of telehealth controls. So these are our general steps that we go through when it comes to doing audit, and I'm not going to belabor this slide, but it just kind of talks about how we address each audit that we do. We're not going to do a primer on auditing. We're more going to talk about what are some things to think about in each of these different areas. And I think the very top one is one of the biggest things that we think doesn't get developed properly by us in the scope of audit. And sometimes it's just we find that individual organizations will look at the telehealth, but they'll just focus only on that code that occurred for telehealth, not anything else on the claim. And one of the things that we do is we like to look at the billing component of it to see if there's some actual risk related to what happened after it left the physicians and how did they communicate back to the provider what changes needed to be done. So one of the first areas is data mine, and as most people know about me, I can talk about data for hours and hours, but I'm going to keep myself focused on this. But really, having your data is going to help you be able to plan how you're going to dig into this. And one area is just maybe just to get a listing of the codes, the services that were provided that's on the Medicare listing, and other indicators that might trigger that you know that that particular area is one that you need to look at. When we've asked, when we've asked individuals about organizations about this, they often struggle about, really how to identify. We've had some clients that actually have a little indicator in their system that indicates that it is a telehealth, so it's pretty quick to get the data out of it. But sometimes it's because they had the same place of service. They had the, some states required modifiers, some didn't. And so you end up kind of sitting there going, okay, which areas did deploy it? So we'll ask, which ones did you deploy telehealth? And then we'll get the data and we'll find and do a short audit and find that they didn't deploy telehealth. So really understanding where your telehealth actually got deployed within your organization and how, who was responsible for that, how did they implement it within their system and things like that. The other thing is if you do have a telehealth module as part of your system or a system that's separate, you may want to see if you could pull the data from there and see what happened with it. That's a little harder because you might be a 50% chance that it's in the telehealth module and it didn't actually occur because the patient canceled, and that's more in your patient practice management system. And then identify certain things on the elements on the claim, like type of bill, CPT codes, as we mentioned, and also look at the originating site facility fee for those Part A people on the call. One thing to think about is if you were to look at your CPT codes that you had prior to COVID, and then where were the greatest increase of volume related to your providers, you may want to focus in that area as well, because there were, E&M visits they were allowed to be billed, and suddenly they went from 3,000 E&M visits, that's a really small amount, but 3,000 to 10,000. How did that happen? Or suddenly we see a ton of E&M visits with tests, things like that. You want to dig into your data and say, this just doesn't look right, and maybe even do it by your specialty area. So things to think about as we've talked about some of these areas already, but you always want to pull information to find out how things were implemented, and that's just really around policy, procedures, and I would say workflow. When we get the workflow, it actually probably has more information on it, as it tells us how a telehealth visit might have been stopped somewhere for review and who touched it, what department touched it, those type of things. You look at those training materials, but also did some states actually required training of the providers in order for them to provide telehealth services? Did your providers actually get that training? Particularly we're picking on the West Coast today, but particularly the state of Washington, it was required. Knowing when the changes happen, and we talked about that already, but then also what happens after the telehealth visit completion, and what is that required follow-up, even in your follow-up of payment related to it? And did you get paid at the right level? When we've received data from clients, we've noticed, that they paid at the 100% of allowable. So we asked the question, is that what the payer said was going to be the allowed amount? And they have to dig and scurry through to find out what was what was going to be allowed during the PHE for that. What's your protocol for disconnected sessions, where you have a patient on video and suddenly they lose their data or they lose access to talking to you via video? What do you do? What's the protocol? How is it supposed to be coded, and how is it tracked that way? And then just the whole provider credentialing, which we beat up on, but really understanding who were the providers during the PHE and during the period that you're looking at, and then when did they leave, so that we understand from the data what's going on. So we have put together some kind of audit questions to ask, which we've all kind of addressed already, but just some comments and notes of thoughts about it, what you should be asking and what you're trying to get from that. And, from patient consent, the telehealth consent forms, to who's monitoring the changes in the organization for telehealth, who's educating the providers, and how staff and teams as well. So these are just some questions that you can use yourself that we've kind of built into our projects. It's also what payers are being billed who were you doing telehealth services and billing for, and probably all your payers. Do you know all the different rules and requirements of all the different payers? And then also, what type of services being provided? Are they mostly telehealth? Do you have a lot of virtual check-ins, e-visits, remote patient monitoring? What's actually showing up in the actual services that have been billed and paid, and et cetera? And then just looking at any of those retroactive changes that happen, because when we get the data, we find that that's occurred, and we have to then trace back really what happened on the retroactive change, or was it just a charge correction? And then is there a monitoring process in place for coding issues? And we've kind of addressed some of the areas we've seen in audits, but we talked about departments that didn't really know where they deployed it. So we had to, roll back and say, okay, what data do we need for which departments? The no patient consent we talked about there, the provider's wrong place of service, and pretty much everything not payable are included under the fee schedule. So this is just some things that you can always focus in on when you're doing your auditing. So we're in our last 5 minutes, and I'll ask Sabrina to pipe in some things as well, but I would say that, it's continually evolving, and the regulations are changing, the state's regulations are changing, the commercial payers, and how you can use telehealth. There's a lot more ways you can use it than, that, like, for example, some organizations are using it for services to help keep that patient active and ensuring that they're getting a chronic care treatment, or they're paying attention, using certain tools and technology to help them track and monitor that patient one of the things we've seen is medication administration, making sure that they're actually taking the medicine, and there's little devices that can track if somebody hasn't taken that, it's in their home. What are you going to do with PHE? What's going to happen with the workflow? How are you preparing for that now, or is it too overwhelming because it's still a long ways off and there's a lot of things between now and the end of the year? Making sure that you look at that workflow when you're doing your audit. And then I think just continually data mining, and we heard that probably at 8 of the 10 sessions that we attended last week from regulators, that you should be data mining. You should have a risk profile, and you should be regularly looking at it, which if you can figure out a way to automate that and make it so it's not something you have to mine and then, play with the data to get it to work, then that's the direction to go. So find ways to help yourself assess your risk. So we did also include in here some audit tools, things you might want to have as your attributes related to doing an audit. And so we just have some references in here. And then the last slide we have on here is some direct links that you can use once you get the slides to go in and look at particular regulations and guidelines. So with that, I'm going to turn it back to Amy. Oh, Sabrina, did you have anything to add?
Yeah, I did want to just say, I was able to finally get into the chat, and I was able to see just really briefly some of the questions. That's which I'll answer, responsively back to the person asking the question. But one of the things I did want to comment is there is a fantastic website for those of you concerned about cross parity with state laws, and it's called the Connected Telehealth Center it's the Telehealth Center for Connected Health Policy. And that, you can look it up, but I'm happy to provide you a link to it. And it helps you understand state laws and crossing. Your provider's in the state of Nevada and you have a patient in the state of Arkansas. And it helps you understand what the rules are for each of those states and how you can cross rules. And I know there's a huge national conversation going on that I'm going to be listening to later about state laws. So I'll see if I can't provide some more insight into that. And I'll hand it back to you, Lori and Amy. Thank you for allowing me to opine on that.
Great. Amy, I'll let you finish it up.
All right. Well, thank you, Lori and Sabrina, for a really great presentation today. And I also wanted to thank our audience for being engaged and submitting your questions to help guide today's conversation. If we didn't have time to answer yours, we will do our best to follow up with you after the webcast. Also, feel free to reach out to our presenters if you have additional questions. And then I also wanted to call out the image in the upper right-hand corner of your console. You can click on this banner to be taken to the registration page for our annual healthcare conference, which is next month in Las Vegas. So definitely check that out. And then also, if you met all CPE requirements, your certificate is available to download now in the CPE progress window. A copy will be emailed within 2 weeks if you have difficulty downloading it now. And then finally, here's a link to an online survey for today's presentation. And thank you for joining us. We hope you'll join us again next time. Take care.